Good day, everyone. I have no conflicts of interest to declare. I am Erlinda Oracion from the Philippines, and my topic for today is creating a culture of anesthesia safety in the Philippines. Charles Darwin said, "It is not the strongest of the species that survives, nor the most intelligent. It is the one that is most adaptable to change." And that is exactly what happened to the Department of Anesthesiology and Perioperative Medicine of the Rizal Medical Center when it found itself at the crossroads of the evolution of the profession. We needed to review and implement procedures and care processes, improve intraoperative patient care through clinical practice, enhance the specialty image, attract high quality house staff, and advance intellectual domain. We were, after all, perioperative physicians. But that was daunting because we needed to survive and prosper in the changing landscape of healthcare. We needed to have excellent continuum of care, have relevant new information, and learn healthcare economics using evidence and outcome based provision of care throughout the preparation, conduct, and follow up of our patients. And we had to use, of course, the monitoring tools and equipment that we had. So, how did we address anesthesia safety then? We decided to have team norms, greet everyone with a smile, be passionate about our work. We revised our department manual to encompass all the processes in the perioperative period and aligned it with OR policy. Our anesthesia record also developed more by having three records: pre anesthetic assessment, intraoperative anesthesia monitoring, and the post anesthesia care unit record. We also initiated collaboration with other institutions. We allowed our residents to go on rotation for certain subspecialties and encouraged our graduates to go for fellowship training. On the ground level, what did we do? Well, we started with labeling our syringes using international color codes in order to minimize medication errors. We had proper sharps disposal bins in order to reduce needle stick injuries. Our documentation has evolved from pre anesthesia records, surgical safety checklists, intraoperative anesthesia monitoring, and an endorsement record and monitoring record at the post anesthesia care unit. Our anesthesia machine check started off by manually doing the machine check, but with highly sophisticated machines now, it has become automated. Personal protective equipment was also provided to our staff and is still being provided to them. But more than that, we have provided them with simulation videos to show the proper donning and doffing of these PPEs in specified areas. Intubation protocols and sedation protocols were also provided to them to address the COVID patient. More than that, of course, is our monitoring and technology has also improved to ensure patient safety. We had ultrasound for the peripheral nerve blocks and difficult airway equipment for the more difficult airway cases. Of course, for our technology, monitoring also has improved. We started to have our invasive monitoring equipment as well. As for strategies and innovations, teamwork, communication, and delegation was important to us. So we invited other departments to have multidisciplinary team and family conferences for complex cases. We continued to coach and mentor our resident staff. As for the learning culture, we started with an S-bar format in our mortality and morbidity conferences. We had critical incident reporting and online examinations to continue evaluating our performance. Work environment optimization involved the use of continuing quality improvement methods. And because of this, we were able to institutionalize moderate sedation policy to ensure that patients were safe even if sedation was done by non-anesthesiologists in out of OR areas. Our tech-savvy resident also developed an app for our department, which is available in iOS and Android mobile devices. And this app contained a lot of information. We had our census for intubation, OB patients, surgical patients, our pain management patients. We also had crisis management resource files that would be available to the staff anytime, real time. We also had files with consultants' lectures, guidelines, modules, and protocols, which could be reviewed, learned, and updated anytime by our staff. The oversight of a safety culture at a national level begins with the Philippine Society of Anesthesiologists, whose mission is to promote and maintain a community of responsible physicians who can practice safe and quality care. And how did the society do this? They provided for us a platform for continuing medical education and distance education. Remember, the Philippines is an archipelago. We also had annual and mid-year conferences, and the society promoted the guidelines for safe anesthesia practice. Recently, simulation workshops were initiated by the society in order to help us in our management of our critical patients. There is another oversight for us. It is the Philippine Board of Anesthesiology, whose mission now is to improve the quality of anesthesiology healthcare in the Philippines by ensuring and improving the quality of graduate medical education for physicians in the anesthesiology training programs. And this is done through the accreditation process. So our institutions with training programs are visited, and we are required to meet minimum standards in the safe practice of anesthesia, set requirements to prevent physician and patient harm. This visit is also an avenue to identify and develop safety initiatives from a third-party perspective. We are also able to promote safe anesthesia culture and standardization of process. But it does not end there. As individual anesthesiologists, diplomates of 10 years or more since conferment, or 10 years or more from the last examination, are required to take a certification of continuing demonstration of qualifications by taking the cognitive MCQ examination and hurdling the anesthesia crisis resource management module. So this is really good because it keeps our anesthesiologists updated and allow us to ensure that safety is practiced over time. So when you talk about anesthesia culture of safety in the Philippines, we're really talking about recognition of high-risk activities, commitment to achieve safe operations, environment where adverse events can be reported without blame, the promotion of teamwork to address problems in patient safety, and the commitment from the organization and from leadership. This is also what has been required by the Agency for Healthcare Research and Quality. So, remember, patient safety and the quality of care are complementary. So, unless safe anesthesia is provided, safe surgery will not be possible, and the safety of patient cannot be ensured. Safe anesthesia is equal to safe surgery, and our outcome, of course, is always a safe patient. As anesthesiologists, we are by your side, bringing the highest standards of knowledge, safety, care, and confidence. Semper Vigilance, the Filipino anesthesiologist who is always vigilant. Thank you for your kind attention.